But today it's my extreme pleasure to introduce Alan Weil, who's the Executive Director of the National Academy for State Health Policy, has been since September of 2004. NASHP is an independent, nonpartisan, nonprofit research and policy organization dedicated to excellence in state health policy and practice. And Alan, before that, has served in a cabinet position with the Colorado Department for Healthcare Policy and Financing, and he's also served as general counsel with the Massachusetts Department of Medical Security. So Alan knows whereof he speaks. He knows what other states around the nation are doing, grappling with the same issues that you all grapple with every week. And it's my deep pleasure to have the opportunity to present him today.
Thank you, Dr. Cepeda. Thank you, Chairman Birch and members of the committee, for the opportunity to be with you today. I appreciate the time that you're dedicating to this important issue, and I'm going to try to answer the question, at least in part, of how Kentucky can achieve its healthcare goals in the era of the Affordable Care Act. In my presentation, I will quickly outline why it's so important that we improve the healthcare system, talk about your opportunity to define your own priorities and use the tools of the Affordable Care Act to promote those priorities. I went to a lot of healthcare meetings and conferences in the 1990s when we were having this debate last time, and you could count on someone putting up a slide that said something like this: quality, access, and cost, we can have two, but we can't have all three. The sense was, we can afford to give everyone something lousy, or if we want to give everyone something excellent, we're not going to be able to afford it. And in that environment, everyone retreated to their own corners and pursued their own agenda. And this is what we have to show for it as a country. We have the highest spending in the world, whether it's as a share of GDP or as a dollars per person. We have the highest barriers to care due to the cost of care compared to our competitors internationally. And we have significant lost opportunities for people to receive high quality care relative, again, to our competitors who are able to prevent premature mortality at a rate much higher than we are because they provide appropriate access to healthcare services. And of course, you see this play out in Kentucky. This is data from the Commonwealth Fund, which has issued a scorecard on state health systems. And it's no news to you that there's opportunity for improvement. That opportunity exists around the country, but I think it is notable, some of the statistics here in Kentucky. The good news is that in 2010, we saw a different way of talking about healthcare emerge. Instead of viewing quality, access, and cost as competing, we now see them as potentially self-reinforcing. It turns out that higher quality care is actually lower cost. It turns out that better access to care can improve quality and reduce cost. And today, rather than saying quality, access, and cost, we can only have two, but we can't have all three, I think it's fair to say that today we understand that quality, access, and cost, you can't have any of them unless you have all three of them. And so we need to work on all three of these fronts simultaneously. Of course, as a country, the approach that we've taken to addressing those three areas is the Affordable Care Act, and I readily acknowledge the variety of views about the law. As I go around the country working with states, there's some people who look at the Affordable Care Act and see a big set of opportunities for flexibility. The law goes where they want to go, and they're going to pick their path inside the boundaries of the Affordable Care Act, and they're very comfortable with that. There are others who have a sense of where healthcare ought to go, and they view the Affordable Care Act as a little tiny target that's nowhere near their own vision. I'm not here to debate or argue with you about who's right and who's wrong. What I want to do is to try to offer you a framework for pursuing your own state's goals consistent with the opportunities that are afforded to you by the law. As I've gone around the country, what I've been struck by is the variety of concerns that different states have about their healthcare system. And what I'm observing is that those states that are doing the most with the opportunities created by this law have had a process of thinking about their own priorities, and they're using their priorities to define their approach to implementation. What do I mean by that? There are a lot of different ways of thinking about healthcare, and there are a lot of needs. These aren't mutually exclusive, but they are a place to focus your energy. In my home state of Virginia, where the Attorney General was the first to sue the federal government, where the governor is strongly opposed to the law, our health secretary, a physician, is committed to improving the functioning of the healthcare system, better integration of care, better coordination of care, viewing the current fragmented system as one that is not meeting the needs of the citizens of the Commonwealth of Virginia, and they are looking at the law and saying there's much we don't like, but our priority is health system improvement, and we're going to use the tools available to us. I look around the country and I see many states where there are disparities in health outcomes across race and ethnicity, across income, across rural-urban divides, and I see states that are saying our priority is to find opportunities to reduce these disparities that to us are evidence of the health system not performing as well as it could. There are states with very high numbers of people without health insurance who are focused primarily on the opportunities the law creates to expand coverage and to give people continuous coverage so that they can have access not just to episodic emergency care, but to continuous care to manage their chronic conditions and prevent them from deteriorating. I see states that are focused on population health, where they see diabetes, they see asthma, they see other conditions that are affecting the ability of their citizens to live healthy lives, and they are saying, how can we reduce the burden of illness and disease? There are states that are focused very much on engaging the patient and the consumer, finding opportunities for people to play a bigger role in their care, so-called shared decision-making, where we've learned with a tremendous amount of research that many people actually are getting care that they don't want. The healthcare system sort of swallows them whole and determines the course of care instead of engaging them as partners in care, and there are many states focused on that. There are states that are working with information and transparency, trying to harness the force of markets and consumer choice to enable people to make better choices. My job here today is not to point you in the direction of one particular set of priorities or to create a hierarchy, but just to indicate that people around the country are looking at their own healthcare systems and making an effort to define their own priorities and then using that to guide the next steps that they are taking. So I thought, just for the purpose of illustration, I would take an example that I've heard is of great interest to people that I've spoken to in Kentucky, and talk about how having a priority, a vision, can then help you think about implementation of the law. So let's say that as your top priority you want to improve population health. Certainly the conversation you just had and plenty of other evidence suggests the importance of this as a goal, not just in Kentucky but throughout the country. Well, where might you want to take that topic? What might it lead you to want to consider as you're not just implementing the Affordable Care Act, but making any policy in the healthcare arena? Many start with the issue of professional licensure. You have areas of your state with inadequate supply. You have many tasks that are performed by physicians that could be performed equally and sometimes more effectively and more efficiently by those without a physician's training. If you want to meet the needs of the population, you need to think about who is performing those services and how they are regulated. You have a very large medical training institution in your state. Are you asking that institution to train the workforce that you need to address population health issues, not just the acute care treatment that dominates the healthcare system? As we reorganize the healthcare system and expect it to deliver results of improved population health, are we holding medical professionals appropriately liable, or do we need to think about the liability structure and redesign it so that we are not putting up barriers to people receiving the care they need? We need to look at our communities and ask what resources they have and maybe what resources are they missing. Some states are building teams at the local level that are focused very much on population health. Those community health teams are staffed by people with training often far short of that of a physician or even a nurse, but they are able to engage with the public and achieve health improvements that are many times the cost of their services. If we want to improve population health, we need to assure that people have continuous access to services. And so as you're building your Medicaid and health insurance exchanges, you need to think about how, as people's circumstances change, they can retain their health insurance coverage and not fall through the cracks, so that their chronic conditions can be managed and their access to care is continuous. Population health improvement requires a strong data infrastructure. You need to monitor the burden of disease. You need to question your performance and hold people accountable for improvement. That happens only with data and analysis. Ultimately, much of the country is moving to changing how we pay for health care, moving away from paying service by service and moving towards payment for improvements in the health of the population. What role does the state have to play in this? Having just listened to your conversation about the role of regulation and markets, this is an opportunity for using market forces to redirect the healthcare system to the goals we have and away from an older payment method that has built capacity but not always better population health. And that leads to how you procure and purchase as a purchaser, not just as a regulator, and how you work with your private purchasers and payers as well to build these payment models so that we can build a healthcare system much more focused on population health. I walk through this exercise, again, not to say this is what you should do, but to illustrate how choosing your priorities and looking around the country at other states and how they are approaching those priorities helps build a roadmap for the decisions that you face and the decisions that you are making. If I had used the example of patient engagement and transparency, there would have been a somewhat different list. My goal is to encourage you to make your own, not to adopt mine. So as you move forward, oh, I'm sorry, I have one more bullet here that didn't make it onto the printed copy, but I already alluded to multiple payers, the public sector working with private payers to encourage these kinds of changes. That's, I think, the path to the improvement that you are seeking. As you look forward, there are many dates before you. You're probably aware of some of these. In October of this year, the Health Insurance Exchange begins open enrollment. And then in January of 2014, under the federal law, tax credits become available to make coverage more affordable for moderate income families. Coverage begins in the Health Insurance Exchange. The opportunity to expand Medicaid to people up to 133% of poverty takes place, and there are major changes in how health insurance is rated and sold. So my message to you is to look at your priorities and to look at the decisions you're making as these dates approach and try to line them up. So I want to, as I finish up my prepared remarks, give you a sense of some of the issues that I've heard within your state and in other states, and some of the opportunities that I hope you will consider so that you can achieve the goals that you have set for yourself. One of the areas of opportunity is the movement around the country toward patient-centered medical homes, and in the Affordable Care Act, so-called health homes designed to improve coordination of care for people with chronic conditions. The movement to patient-centered medical homes is based on an understanding from research that stronger primary care is the pathway to better health outcomes. We've been monitoring states that are pursuing health homes under the Affordable Care Act and can show you the states that are planning and seeking approval from the federal government to get significant additional funds so that they can build out an infrastructure to help serve people with multiple chronic conditions. We also have significant movement in this country to improve care for people eligible for both Medicare and Medicaid, the so-called dual eligibles. These are the frailest and most at-risk people amongst us, and yet poor care can lead to poor health outcomes and high costs. Again, here is a map of the states around the country that are pursuing demonstration projects to redesign care for this very complex population. I already alluded to the importance of pursuing alternative ways of paying for health care so that we're paying for value and outcomes and not just procedures. My organization is monitoring states that are pursuing so-called accountable care organizations designed to let providers, often hospitals and physicians, work together to improve population health. And these are some states that are taking a variety of approaches to trying to build more accountable care systems. I also mentioned the importance of data to monitor your performance and seek improvement. Here's a map from the All Payers Claims Database Council of states that are building out their data infrastructure so that they can monitor health claims and use those to pursue improvement. I have heard from many that there's concern about the pace of the move to Medicaid managed care, and so I thought I would just spend a moment on that topic. I would remind you that actually most states, including when I was in Colorado in the early 90s, that was when most states moved their families and children into managed care. So we have a lot of experience with this. And as I noted, the focus was on lower cost populations. And I can assure you from my personal experience and from the research that no matter where and when you do this, it is disruptive. But over time, we really have built an evidence base to suggest that it has positive, on average, positive consequences for health and somewhat positive consequences for costs. So despite the risks of disruption, I want to assure you that those disruptions do settle down eventually. Today, much of the country is looking at moving elders and people with disabilities into managed care. This is a much more complex issue, many more dollars at stake, but a much more complex population. And I would just assure you that people are working on this issue as well. So it's an area to address with caution, but one to understand that you are not alone. Particularly in the southeast of our country, local health departments have a tradition of delivering direct services, and these transitions can be very disruptive for local health departments as well. Again, we have some experience around the country with this issue, and I want to just mention quickly how some states have approached making sure that this is not too harmful to local health departments as we move into a different kind of delivery system. In some states, local health departments were included in the networks of care as the state moved into managed care, or they provided plans with incentives, higher payment levels, if they included local providers. In some states, not just health departments, but also local public hospitals built their own networks so that they could compete on the marketplace. Some gave higher payments to those departments. But this history is almost 20 years old, and I do want to remind you that the healthcare system is very different today than it was 20 years ago. So I would encourage you to learn from other states' experience, but also to build what works for you. Mr. Chairman, in closing, I would just note that my organization has built a learning space for states so that they can learn from each other. It's called State Reform. It's a website open to anyone at www.statereform.org. We share documents, ideas, questions, and comments so that you can set your priorities and find others who share them. As I have discussed what is going on in Kentucky and compare it with what's going on around the country, I will say that you should take some comfort in the notion that there's a very high level of coordination across your insurance exchange, your health department, your Medicaid agency, your insurance division. This is not the case everywhere in the country. It's that kind of cooperative approach that I think is necessary for setting an agenda and then achieving it. So again, with a full understanding of the political complexities associated with the law, I want to close on an optimistic note that if you are clear in your own priorities as a state, and you are willing to learn from other states about their approach, I think you will find much to work with that you can use to improve the health of Kentuckians and the other goals that you may have. And my organization and I are here as a public resource and happy to offer whatever assistance we can provide. Thank you.
Thank you, Alan. Representative Flood.
I wanted to thank you so much for this presentation. It literally is what I have been wanting to frame up as we likely expand Medicare and Medicaid in the state in the years ahead here, how to wrap around priority setting process. So I'm so grateful for this work and to the chairman for this presentation. And with that, Mr. Chairman, forgive me, I do have to slip off to one more meeting, but I wanted to thank you for this.
Robert.
Thank you, Mr. Chairman. And I understand that your presentation was not meant to be exhaustive, obviously, or we'd be here for weeks probably. And I certainly appreciate the presentation. One thing that I did not see in there, unless I missed it, was the role of patient accountability in all this, and especially in our Medicaid program, beneficiary accountability to reduce overutilization, and quite frankly, so that every individual has skin in the game when they make healthcare decisions. What have you seen about that across the country?
Well, I think there are really two sides to the patient accountability coin. One is the financial side of assuring, as you refer to, the skin in the game. The other is building a healthcare system so that as people interact with it, they're able to use it appropriately. So one of the cautions that always arises when seeking to change patient behavior is if you want people to do something differently, you have to make it possible for them to do it, or else you're just penalizing them for a system failure as opposed to their failure. I will be clear that the Medicaid program has some fairly tight constraints on the ability of states to charge individuals for receiving care, particularly limitations, prohibitions for pregnant women and children, and fairly low per encounter costs for people above those levels. The federal government did recently offer some new guidance, slightly lifting those rates, opening the door to things like encouraging generic drug utilization so you can have some price differences there, discouraging inappropriate emergency care utilization so you can build some differences there. But for the lowest income population, federal law still does prohibit more than nominal copayments. I would say that in the once you start moving above the poverty level and you move into those who may obtain coverage through the health insurance exchange, the benefit structure within the insurance exchange is going to have significant deductibles and copayments. So while Medicaid still operates with some very tight constraints, you will find that people living on $15,000, $20,000 a year are certainly going to have a significant amount of skin in the game as they interact with the healthcare system if they're getting their coverage through the exchange. So we do have a little bit of a difference between what the rules are in Medicaid and what they are outside. And as I say, there is a limited change in federal policy, but by and large, the federal limitations on financial cost sharing remain. The other optimistic note here is that I believe as the healthcare system as a whole moves more to population accountability, which I really see it happening around the country, many of the roots of inappropriate utilization are being addressed on the supply side instead of on the demand side. So why do people go to the emergency room? Because their doctor's office is open from 9 to 5 and they're working and they don't have paid leave, or they don't have daycare for their kids that they can leave them there while they take the sick one to the doctor. As health systems find themselves accountable for population health, they're setting up the 24-hour call line. They're making sure that there's 24-hour access, not to an emergency room, but to maybe a nurse health line. So as the system moves more to patient level of accountability, it's actually being redesigned in a way that better meets patient needs, which hopefully will have some effect. So I think we have to play on both sides of this, both on the individual responsibility side and on the responsibility of the healthcare system to be designed around the patient's needs as opposed to its history of being designed around the provider's needs.
Thank you.
Susan, if you can condense your presentation, we got another presenter behind you all, and we have to move along pretty quick. We got to go in session at 2 o'clock unless you're not going to present.
Thank you. I have no other presentation. The point of coming here today was to underscore that the Foundation for a Healthy Kentucky is here to serve you as policymakers, and one of the ways that we seek to do that is by bringing people with expertise at the national level and from other states into the deliberations here and giving you access to the wealth of knowledge that lies behind Alan's presentation today.
Thank you so much.
Thank
you
you.
both for your presentations.